Assalamu alaikum. Good morning everyone. Today we're going to talk about patient care in operation theatre and management of high risk patient. So first of all, briefly we'll discuss about management of patient and special care that we just take care of the patient in operation theatre. The care a patient usually require in operation theatre depends upon the type of anesthesia and the surgical procedure going to be carried out. Generally, the patients are being operated in either under general anesthesia or spinal or under local anesthesia. The better way for understanding the optimal care is according to a well-known saying, that is, we care you when you are unaware. Patient care mainly depends upon the type of anesthesia is being used. Like if the patient is under general anesthesia, so that patient required utmost care from the entire team, depending upon the surgeon, including the surgeon, anesthetist, and the OR assistant as well. Because the patient is unconscious, he would require care of whole of his body and other things as well. While the patient that are going to be operated under spinal anesthesia, they are aware but they cannot move certain part of their bodies. So if they feel any problem like hypothermia or hyperthermia, or they are feeling any problem related to some medication, they can communicate with the surgical team or with the anesthetist. While the patient with local anesthesia, they can communicate and even they can mobilize their body part as well. Theatre environment play a vital role in overall care in operation theatre, like adequate temperature control, that is varying from 18 to 24 degrees Celsius with an average of 21 degrees Celsius is required in most of the operation theatre to have optimal care and reducing the morbidity and mortality and post-operative wound infection as well. But it depends upon different countries and different weather environment as well. Humidity should be controlled. It's usually ranging from 50 to 60%. And modern theatre, they do have laminar flow and negative pressure theatre rooms to minimize airborne infection and to spread infection from one patient to the rest of the team and other theatre rooms play a vital role, and the theatre cleansing team is most important, taking care of this aspect of the operating room. Next we will talk about one of the most important component used in operation theatre is instrument related. There are different type of instruments that are being used in operation theatre, like surgical instruments and the instrument for maintaining IV lines and for needles using like IV lines to operate on the patient. These instruments are known as critical instruments, while those instruments that come in contact with the intact mucosal membrane but they are not breaching it, like endotracheal tube, nasogastric tube, Foley's catheter, they are considered semi-critical instrument. The critical instrument have sterilization at, while semi-critical, of course, they should be sterilized, but in certain should be clean and the environment should be clean before we insert Foley's catheter or like nasogastric tube. Instruments like the shifting table, the operation table, they should be clean, considered non-critical instruments. There are certain factors related to patient, like age of the patient is very important, particularly at both extreme of age, children and old age people. Children, they cannot maintain their body temperature, so special care should be undertaken to maintain their body temperature. Similarly, shifting of the old age patient is very important to take care of their joint and their temperature control as well. The next thing is position of the patient. The patient undergoing surgical procedures, and every surgical procedure have its own position. Like in general surgery, if the abdominal surgery is going to be carried out, it should be done in supine position. But for some other surgeries, like spinal surgeries, the patient might be in prone position. So if the patient is in spinal position, then special care should not be required as compared to a patient in lithotomy position or in prone position. But of course, we should take care of cervical spine, and special care should be given to the joint and to avoid nerve compression, particularly in patient with like thyroidectomy in reverse tendon position, where there is a neck extension, so neck cervical spine stabilization should be performed. And nerve compression to be avoided, like sciatic nerve compression and the common peroneal, while the patient is in lithotomy position. Temperature care we already talked about. There should be the theater environment and temperature should be controlled, and if the patient is feeling hypothermic, so the warmer should be applied in the form of blanket or by air fan. Eye care, particularly patient under general anesthesia, eye care should be done to avoid exposure to keratitis. So certain type of ointments or eye drop along with closure of the eyelid while the patient is unaware should be performed. Special care should be given to the patient while shifting from operation table to a shifting trolley and to the recovery room, particularly after general anesthesia and as well as for spinal anesthesia. Ideally, there will be two persons, one from the head end and the other one from the foot end. The head side would be from the anesthesia people taking care of head and cervical spine, while two people on either side, and a total team comprises of 6 persons along with the shifting board to carry out the patient from operation table to a shifting table and then from shifting table to recovery room. Now we just briefly talk about assessment of the high risk patient. Despite high risk patient presenting for surgery, the perioperative mortality has decreased significantly over the last half a century, especially in the source-rich countries. There remain a subgroup of patients who are at high risk of morbidity and mortality after surgery. By identifying high-risk patient in the perioperative phase and planning their perioperative management, morbidity and mortality can be reduced. Patients who have a predicted mortality of 5% or more than 5% should be considered as high-risk patient. It is estimated that though the high-risk group account for less than 15% of all surgical procedure, according to one study that was done in UK, according to that, they contribute to more than 80% of all perioperative mortality. What are the factors that put this patient to a high risk of death and complication after surgery? There are factors like tissue destruction, significant amount of blood loss or significant amount of fluid shift, changes in temperature, patient with excessive anxiety and pain, and of course there is increased demand for oxygen delivery to the tissues. Normally it's around 110 ml per minute per square meter of the body surface area at rest, and that demand increased to 170 ml per minute per square meter in postoperative period. Now the patient factors that predispose the patient to high risk of morbidity and mortality includes previous severe cardiopulmonary disease like acute myocardial infarction, COPD or stroke, late stage vascular disease involving aorta, age more than 70 years with limited physiological reserve in one or more vital organs, extent for carcinoma, acute abdominal catastrophe with hemodynamic instability like patient presenting with peritonitis, blood loss requiring transfusion of more than 8 units, patient with septicemia, blood culture positive or that put the patient being on high risk and with increased risk of morbidity and mortality. There are specific surgery related, like there are some low risk surgery or intermediate risk or high risk, like simple breast surgery or thyroid surgery or simple gynecological or minor orthopedics and minor urology surgery are considered as low risk with the elective abdominal like carotid or endovascular surgeries, particularly for aneurysm, major head and neck surgeries or of around 1 to 5%, while high risk surgeries include open aortic, major vascular, peripheral vascular or urgent body cavity surgery. We should identify high risk patient and try to minimize the morbidity and mortality by not, but also managing the problem. Like if a patient with unadjusted the mortality would be around 5.97%, while after adjustment and stabilization of the patient, the 30-day mortality would decrease to 2%. Similarly, abdominal surgery from 2.73% to 1.83%. Orthopedics 1.25 to 0.49%. The key to management of high risk effectively is the identification and accurate quantification of the risk and subsequent to minimize it. Realistic estimates of the cornerstone of informed patient consent and decision making. The patient and the surgeons may choose a less extensive or even a non-surgical options where risks of the definitive procedure are deemed to be too high or unacceptable. There are different scoring systems are used to identify high risk patient. The most commonly used system for identification of patient are AS scoring system, metabolic equivalent score, P positive system, ACS scoring system, and cardiopulmonary exercise testing. Optimization of high risk patient. The main system that need to be focused on and need management from a multidisciplinary team would be focused on ischemic heart disease, minimizing myocardial ischemia, improving cardiac failure, and particularly improving respiratory reserve, particularly in patients with respiratory failure. Thank you very much for your attention. Kindly mark your attendance in that comment section below, and if you have any question you can ask as well in the comment section below.